Everyone. Good morning. Welcome to the Pan American Health Organization Office for Barbados and the Eastern Caribbean countries webinar. Our focus this morning, COVID-19 vaccinations and international travel. The role of the vaccination passport and immunity certificate to revive the tourism economy in the Eastern Caribbean. My name is Nicola Barito, and I will be with you this morning for this virtual session. Let's begin with this. Safe and effective vaccines will be the game changer. Now, the global rollout of the vaccine is indicative of the ultimate goal. And of course, we know the ultimate goal is ending the COVID-19 pandemic. Now, more than 1.26 billion doses have been administered in over 134 countries. Now, many are racing to have their populations inoculated by the end of 2021. And we know that's very ambitious, given the fact that the reality is a widespread global vaccine rollout will take at least 12 to 24 months. Now, I'm quoting from the IHR Review Committee, which has advised member states, at the present time, do not introduce requirements of proof of vaccination or immunity for international travel as a condition of entry, as there are still critical unknowns regarding the efficacy of vaccinations in reducing transmission and limited availability of vaccines. Proof of vaccination should not exempt international travelers from complying with other travel risk reduction measures. Now, that's why we are here. This virtual session is a platform to create a forum for discussion on utilization of vaccines for the reopening of economies. And we are very hopeful that this will yield positive results as we move forward in the fight against COVID-19. So just allow me to give you an idea, a rundown of what you can expect this morning. We will have a few presentations, and we also will have a panel discussion. This morning, we will have a presentation from Dr. Sean Charles, who is the CMO, the Ministry of Health in Grenada. He will focus on the country experience, vaccination, public health, and international travel. We also have panelists, Dr. Aisha Andrewen, she is the Chief Medical Officer, the Ministry of Health in Anguilla, Dr. Arthur Phillips, Senior Medical Officer, the Ministry of Health in Barbados, and Ms. Lisa Valmont, she is the Permanent Secretary, the Ministry of Tourism in Dominica, along with Dr. Roberta Andrighetti, she is Regional Advisor, International Health Regulations, PAHO WHO. She'll be doing a presentation as well. But before we do anything else, allow me to invite Dr. Italis Gipre. He is PAHO WHO representative for Barbados and the Eastern Caribbean countries. Dr. Gipre?
Thank you. Ms. Barreto. Good morning. Colleagues from the Ministry of Health, Chief Medical Officers, officials, and permanent secretaries, panelists and speakers, ladies and gentlemen, attendants, let me thank you all for being here this morning. I extend a warm welcome to you all on behalf of our PAHO Director, Dr. Carissa Etienne, and WHO Director General, Dr. Tedros Adhanom Ghebreyesus, and all of us from PAHO Barbados and Eastern Caribbean. As you know, COVID-19 has enabled significant coordination on common regional health protocols for implementing SARS-CoV-2 testing for regional procurement, particularly for personal protective equipment, biomedical supplies, testing kits, and other health-related needs, as well as therapeutic and public health measures. We will learn some examples today from the speakers and panelists how this ran out. Increasingly, we see a two-track pandemic. Many countries still face an extremely dangerous situation, while some of those with the highest vaccination rates are starting to talk about ending restrictions. WHO calls the member states to support a massive push to vaccinate at least 1 in 10 of the population of every country by September 2021, and a drive to December to achieve our goal of vaccinating at least 3 in 10 by the end of the year. To reach these targets, we need additional 250 million doses by September, and we need at least 100 million doses just in June and July. There are four factors that together are a dangerous combination globally for the continued pandemic. There is an increased transmissibility of new variants. There is an increased social mixing, relaxing of public health and social measures, and uneven and inequitable vaccine distribution around the world. Countries must also continue to carefully calibrate how to apply and ease public health measures. As of June, as Ms. Barreto mentioned, 1.9 billion vaccine doses have been administered. So nearly 11 doses for each reported cases globally. PAHO is working to make sure access to safe and effective COVID-19 vaccine is guaranteed for every eligible person, regardless of their ethnicity, economic condition, gender, migratory status, or whether they reside in a city or rural area, starting with the most vulnerable. We are still concerned that the vaccine hesitancy is an issue to utilize the vaccines delivered in the Eastern Caribbean countries. We have close to 170,000 doses, which may expire by the end of June, and 39,000 could be at risk. We call those who need the vaccine in keeping with the national guidelines to come forward and then get vaccinated. Vaccines indeed bring us closer. Evidence suggests that some newly identified variants of concern may have increased transmissibility and as compared to previously circulating variants. It is likely that there will continue to be elevated risk of exportation and importation of cases between countries via international travel, including cases of the new variants. The impact on countries will depend on multiple factors, including whether there is ongoing community transmission and whether health systems are operating at the capacity. Despite the elevated risk, WHO guidance on international travel still holds. It provides national authorities with a practical approach to resume international travel while reducing the risk of travel-associated spread of COVID-19. The details we may hear from the panelists and speakers. At present time, WHO position that national authorities and conveyance operators should not introduce requirements also for proof of COVID-19 vaccination. In addition, considering that there is limited availability of vaccine, preferential vaccination of travelers could result in inadequate supply of vaccines for priority population considered at higher risk for COVID-19. Should the requirement for proof of COVID-19 vaccination for international travel be introduced in the future in accordance with IHR provisions, vaccines must be approved by WHO and be suitable quality and universality available for the protection of all people from international spread of the disease. Although vaccination status can easily be captured via digital means, the ability of uniquely identify an individual and validate vaccination status requires international cooperation, orchestration across complex systems, and widespread adoption. We may learn from other countries through this webinar. We continue to recommend that essential travel should be prioritized and facilitated. We need to open the economy, and then certainly public health measures should continue to apply and to reduce the risk of the spread of COVID-19 through international travel. I welcome you all for this webinar. Thank you very much. Back to you. You are still muted. Ms. Barreto, you are muted.
It would help if I am muted. Thank you so much, Dr. Gibre, the WHO PAHO representative for Barbados and the Eastern Caribbean countries. Dr. Sean Charles, I would like to welcome him now to the session. Before I bring Dr. Charles in, of course, I know that there are close to 400 participants this morning. So once again, we thank you so much for taking part in this webinar. Now, Dr. Sean Charles is the Chief Medical Officer, the Ministry of Health, Grenada. And this morning he'll be doing a presentation, Vaccination, Public Health, and International Travel, the Country Experience. Dr. Charles, good morning.
Good morning to you, and good morning to my fellow panelists and the viewing and listening audience. If you would permit me to share my screen for a moment. Okay, so I'm going to deliver just brief presentation, which will give an overview of the situation in Grenada as it relates to vaccination, public health, and international travel, our experience. Now, our COVID pandemic response and control was based on a few key approaches, one of which was active surveillance, both at our ports of entry and in the community. We had to first address the entry of the disease into the country, and we had to establish or create robust systems to quickly monitor and to detect and control the disease once it entered the country. Secondly, testing was another priority. Prior to the COVID pandemic, we had no capacity to do molecular testing. We had no capacity to do PCR testing. So this is one of the interventions that we had to build capacity in early in our response. And of course, we always like to recognize our partners, such as the Pan American Health Organization and St. George's University here locally, who partnered with us in introducing this technology and allowing us to be able to conduct testing. Then case and contact investigation, very important. We had to significantly ramp up our ability to conduct contact tracing. We had to hire additional persons, do training, and basically decentralize the whole contact tracing operations so that we have teams located in every district, in every parish of the country, and are waiting and are able to respond at a moment's notice when a case or a contact of a case was identified. And of course, we instituted measures such as quarantine and isolation. Public education was also very important because we needed to ensure that the public knows of the measures that are needed to protect themselves. And of course, we needed to convey to them the type of behaviors that favor the spread of the disease and the type of behaviors that we want them to acquire that will be protective. And of course, there were the regulations. When the need arose, our country instituted relevant regulations that restricted, that placed restrictions on many everyday activities. There were periods where we had curfew, all right? And there were periods when we have various limitations in some activities that were happening in the country. But we also placed in regulation the public health measures, such as the wearing of masks, distancing and sanitization, etc. But these measures have largely allowed us to have a great degree of success in the control of the COVID pandemic. Our first case was detected sometime in March, around 22nd of March last year, and our last case was around 24th April. We were successful in preventing the establishment of community transmission here locally, and at present we have no active cases. But we knew that this would not be sufficient, that vaccination, and this was eagerly anticipated, I think, throughout the world. And we knew that this had to be the next step if we are to protect our population. Because what we did with all of the public health measures before was to prevent a significant part of our population from ever being exposed to or being affected by this disease. So in essence, our population remained naive. So we needed vaccination as the next step to provide protection to the population. But of course, we know that whatever vaccine that we acquire, WHO endorsement would be very important for public confidence. And we were very pleased to get access to vaccines and to start our vaccination program around 12th February using the Oxford AstraZeneca vaccine. Our approach was a phased one. We started with our frontline workers. Then we extended to other individuals, such as those with underlying health issues. And at present, the vaccine is available to all persons 18 years of age and above. Now, the thing is, when we embarked on vaccination, we knew that we had an uphill climb. And we knew that we were swimming against the tide because we conducted 2 surveys prior to us receiving vaccines, one amongst our healthcare workers and the other among the general public. And what we found was that the level of acceptance, the anticipated acceptance of this vaccine was going to be very, very low. Surprisingly, among our healthcare workers, we had just about 10% who at the start indicated outright that they will accept the vaccine. But the vast majority stated that they would not. And of course, the concerns were related to side effects, whether long-term or immediate, safety of the vaccine, and other information such as effectiveness and having data or information on the vaccine. So these were the concerns of our healthcare workers. In the general when we did the survey of the general population, the percentage who indicated outright that yes, they will take the vaccine once it's available was a little better, all right? Was a little better, just around 23%, but we still saw that there was a solid, significant majority who at the outset were convinced that they will not take a vaccine. And the concerns were similar. Similar to the healthcare providers, long-term side effects was the main concern. Then we have safety and several others such as effectiveness and having data or information as well. We knew that our working population would give us the greatest challenge because we noted that the younger individuals in the population, they were less inclined to take the vaccine as opposed to older individuals. Now, incidentally, our frontline workers are among those in the younger age groups, generally between 18 and 54. That's where you find most of the frontline workers. And we see that the majority only just a very small proportion indicated outright that they are willing to be vaccinated. So we started vaccinations, and during the first week, when it was opened to only our healthcare workers, the numbers were less than expected. All right, even though we knew that there were some challenges, we thought that once information is provided about the risk and the benefit, that persons will make a better decision, a more informed decision. But the uptake by our healthcare workers in particular and other frontline workers during that first week was quite low. Then we extended to other frontline workers and persons with underlying conditions, and we saw very good uptake. Then by about the 5th week, we started getting the reports of adverse effects in the media, particularly the blood clots, and that resulted in a significant decline in the number of persons who are taking vaccines. The Ministry of Health went about on a media campaign to provide information and improve the confidence in individuals about the vaccines and about taking the vaccines. And afterwards, we saw an uptick in the number of persons being vaccinated once again. But we are once again noticing a decline and a tapering off of persons willing to come forward and be vaccinated. So where are we at present? To date, we have delivered 27,000, just over 27,000 doses. Of the total population, about 16%, 16.5% were vaccinated, and 8.4% have received the second dose. But of the population who are eligible, because the vaccines are now made available to everyone who is 18 years and above, about 21% have been vaccinated so far, and about 10% have received their second dose. So vaccine hesitancy has been one of our greatest challenges. And there are many factors that we have attributed this to. One is COVID. There is a common saying among persons who are refusing to vaccinate is that we have no COVID here, so why should I get vaccinated? That's one of the common ones. The reports of adverse events did not help. Even though they are very rare, they are magnified in the media. So the vaccines are seen by persons in the public as than the COVID. And of course, social media and all of the conspiracies that are out there, they have crept in here as well. At the same time, the industrial climate in Grenada has not been the best. We have our public sector unions that are they are up in arms against the government right now, and there are protests almost every week requesting increasing pay. And of course, we are seeing a reluctance to vaccinate among some of these same public sector workers because it could be as a form of protest. Then the political climate as well. We see that because it's an effort that is led by government, there is pushback against it. From the religious side, there have been mixed messages. There are some religious leaders who have come outright and they've been vaccinated and they've been encouraging their congregations to be vaccinated. But then we have others who are outright against the vaccines, and they are vocal and they are speaking to their congregants and encouraging them not to be vaccinated. And then with influencers, and they come from all sectors. We've had legal persons in the legal field. We've had entertainers. We've had random persons calling on radio programs, spewing conspiracies and discouraging people from vaccinating. We have persons who are into the traditional medicine business who have been similarly vocal, but the effect of all of these is to create confusion in the mind of many individuals, and this is harming the uptake. Then there are other issues. Legal mandate has been debated. It is extremely unpopular, and of course, our Prime Minister has stated his position that he will not pass laws to mandate vaccination. Are not in favor of this as well as a Ministry of Health. There have been lots and the Constitution, and of course, persons are reminded that yes, you do have a right to take or not take the vaccine. However, it was also made clear that businesses also have a right to require vaccination as a health and safety issue. So these are all challenges. In addition, of course, there are priority sectors like the accommodation sector and those persons that work in the front line that have been identified for as they should have their workers vaccinated. These matters remain inconclusive and the debate continues. But the Ministry of Health, what we've done, we've had media campaigns, we've had press conferences, we've had forums with stakeholders, we've had in-person, virtual, and other consultations. We tried to do outreach sessions to reach more of the public, and of course, the offer of incentives is now in play, such as allowing fully vaccinated events, and with regards to travel, reduce quarantine. Now, we have not taken a decision that everyone coming to Grenada must be vaccinated. However, persons who are fully vaccinated and are coming in, the quarantine time is less or has been lessened. So our travel protocol was recently updated to reflect fully vaccinated persons. The PCR test is still required within 72 hours of travel, and persons are tested on arrival. They are quarantined for a maximum of 48 hours. They're quarantined just for enough time to get the PCR results. So it's up to a maximum of 48 hours before being released. And of course, persons who are unvaccinated continue to have a requirement of a 7-day quarantine. This was started in May. And from that date, from the start date of this new entry protocol, we've noticed that the number of persons traveling into the country has more than doubled. All right, so we are still monitoring it. The number of travelers are increasing daily. We are basically doing the best that we can to ensure that we stay protected. We are also looking at the evidence and the recommendations, and we are accepting the best advice that suits our context. So this basically is an overview of our experience so far. Thank you.
Unmute, please. Nicola, you're muted.
Thank you so much, Dr. Sean Charles, Chief Medical Officer, the Ministry of Health in Grenada. Definitely an uphill battle, protecting our populations at the top of the list. We will take your questions later down in the session. So if you have any questions, feel free to let us know. We've got a full team on hand to answer all of the questions that, well, we'll try our best to answer all of the questions provided. So I think we're going to go into our panel discussion at this point in time. And I'd like to welcome once again our panelists, Dr. Aisha Anjouin. She's the CMO, the Ministry of Health in Anguilla. Dr. Arthur Phillips, Senior Medical Officer, Ministry of Health, Barbados. And Ms. Lisa Valmont, she is the Permanent Secretary, the Ministry of Tourism in Dominica. So let's dive right into it. Now, the COVID-19 pandemic has impacted every sector in Barbados and the Eastern Caribbean, in fact, all across the region. Now, with the implementation of certain measures, we have managed to slow the spread and are in the process of rebuilding our economies, many of which are tourism-based, and we can all attest to that. We saw the hotels empty, we saw our hospitality workers jobless within the last year. We heard the cries, and we know the impact that COVID-19 has had on our islands and, of course, on the tourism sector. I am throwing this out to each of you. What are some of the social and public health measures which have been implemented to reduce infection from incoming travelers or nationals traveling abroad? And is there a difference for the business traveler versus the tourist? I actually want to start with the CMO of Anguilla. Dr. Anjouin?
Yes, good morning. So we have a similar experience to Grenada. Just to say that from the beginning of our experience in Anguilla with our first case to now, we have had to transition our response. We have gone from, that has required immense capacity building with laboratory and surveillance, similar to what CMO Grenada shared. We went from testing or sending samples from symptomatic persons to CARFA to having to build laboratory capacity hugely, infrastructure, equipment, personnel, and training, and so on. So we had our first case around April of last year. We had a total of 3 cases, 2 imported, 1 local transmission from an imported case. And then we had a brief lockdown, and we kept our borders closed for a while, and we went a full 8 months with no cases. And we transitioned from to bringing in or repatriating persons to having that mandate to reopening the economy to tourism around October of last year. But we had to have the capacity from the lab in place. Why? Because we implemented, similar to Grenada, testing requirements. A requirement for 3 to 5 days prior to arrival, you have to have your COVID-19 PCR test, RT-PCR, submitted as part of the approval requirements. Testing upon arrival of every single person that entered. But also it didn't stop there. We had a quarantine period that ensued between 10 to 14 days, depending on if you're coming from a high-risk territory or a low-risk territory, which was determined by the prevalence of cases at the time, the epidemiological situation at the time. However, we also implemented testing at the end of quarantine in order to establish that you were safe to be incorporated into the community at large. Now, in response to the question if how we manage tourists, business tourists versus regular tourists, the difference with how we manage persons coming in general had to do with your length of stay in Anguilla. So if you're here for a short stay, meaning that you would never clear a quarantine, we also implemented certain so-called bubble protocols, which was an expansion of the quarantine concept to allow the economy to survive. You wouldn't want persons here locked in a room for the 5 days we were here, for example, so that wasn't feasible. So we devised very strict protocols that entailed training of personnel and certification of personnel. We really had a preference towards activities that could be conducted safely, bearing in mind that these persons hadn't cleared a quarantine and they were not COVID-free at that point in time. And that was a main part of a message to the persons that were trained and to the general public. So for example, restaurants and open spaces, which most of the restaurants here are, well ventilated, water sports and that kind of thing. At the time, we suspended spas and like personal training for gyms for persons who had not cleared quarantine. So that was part of the provisos that we shared with the public and the persons in the sector. Very important to that, we also implemented a low-tech way of distinguishing between persons, the so-called bubble guests and the regular guests and persons who have been repatriated. We implemented a red armband, red bracelet to know persons who had not cleared quarantine. This was very well accepted by the public, and actually it was instrumental in helping us to identify persons who had breached quarantine. So our bubble activities for the short stay guests heavily protocolized, and then everything was built around that testing. Incidentally, we had a question, because testing is resource intensive. There came a point where we had to decide how we manage persons short stay. Do we test them prior to departure from the island? And loosely we said, okay, if you're here more than 5 days, and remember this is a time when countries were still deciding what their re-entry requirements were. So between then and the time when the UK, US, for example, decided that persons returning had to be tested, we were already doing that, especially if you were here for more than 5 days. If persons refused at the time, we kind of let it go if they were here for less than 5 days, but we were really leaning on getting their status before they left. Now it's a moot point because most of these persons need that test to re-enter their countries, so we're also doing that as well. In terms of how we think it has impacted, we know there are controversies around requiring the testing and so on, especially at the beginning. What we can share is that as a first line of defense, we averted more than 30 COVID-19 cases. Persons testing to come in were just COVID-19 at the outset, had to defer their travel. Further to that, after we reopened, we had 28 imported cases. Of those, we had 15 detected on arrival. Now, this is after a negative test pre-arrival was submitted, right? So they tested positive on arrival, and we were able to isolate and contact trace immediately, including our international health regulations requirements and notify the relevant countries. And then we also found that a few more, like 6 or 7, when they were returning to their countries, tested positive. This is like less than a day 7, they would have been here around day 4, day 7. So we saw the benefits of that, knowing that a one-off test does not clear a person. And that's something that we took months to explain to the public. Look, people with that pre-arrival test, it doesn't mean they are not positive. And this was powerful. We also saw the benefits of those protocols where we virtually eliminated high-risk contacts. That worked well. The few breaches we had did not, fortunately, involve persons who had tested positive. So that worked very well for us in our estimation in terms of our protections. Yeah, and like Benita said, a lot of that had to do with that public confidence, cooperation, also the political will, the support from our international partners, PAHO, CARFA, but especially in the UCOT setting, Public Health England was instrumental in getting us our testing capacity and that technical support, and the UK government in terms of helping us man the borders and all the funding that was required for extra personnel and so on and so forth. So I'll stop there because I know it's a short panel discussion and I won't take away from the other panelists. So
it is pretty short, but I just want to really quickly, Dr. Andrew, and you mentioned the armband facility. How well was that received?
Well, initially there was some pushback. So it's a wristband, sorry, right? And then we said to the private sector, well, can we think of it the same way you think of all-inclusive resorts? So it's not that distasteful. And I think the public confidence was the thing that really, and public acceptability, because the local population was safe for the 8 months inside this little bubble that's Anguilla. So they were really receptive to something like that when we had to entertain the shorter stay guests who had not cleared quarantine. And I think that may have been something, definitely something instrumental, the will of the masses. And eventually it caught on and it's become something more accepted than not. So we did have pushback on that, but I think now it's become pretty mainstream for us. So that worked. And the beautiful thing about that is a low tech, because like other countries, we were strapped with, do we implement something high tech, expensive? They talk about these electronic gadgets that can tell where persons are. And we saw the caveats with that as well. So the simple red wristband worked for us fundamentally.
Thank you so much, Dr. Andrew. And Dr. Phillips, tell us a little bit about some of the social and public health measures in Barbados, and also in terms of tourism, the difference between the business traveler and the average tourist.
Great, good morning, and thanks for the opportunity to share. Barbados's situation has a lot of commonalities with those already mentioned this morning, but what I will highlight is that testing, quarantine, banding, vaccination, all of these have been quite important for us. We do currently require individuals to have a test no more than 3 days before coming to the island. So I'm getting a little static. And then we're now testing individuals on arrival and then at the end of their quarantine. The quarantine is in designated or approved settings, and these are monitored by various teams. We've created a cadre of staff, community health liaison officers. We have a COVID-19 monitoring unit. We have we've created several mechanisms to work together to make sure that we can assure the public that we're keeping safe. Yeah, we want the economic activity. We want to keep safe. So the quarantine is supported by monitoring of symptoms. It's also supported by checking that people are where they're supposed to be. We do have color-coded bands that indicate what category of individuals are in, as well as geofencing bands. So you have a band that is linked by Bluetooth to an app on the phone, and this is tied to a location pin. And if the person wanders away or if there's loss of contact, then we'll reach out and try and figure out what has happened. Is an internet outage? Is there a misunderstanding? Is there an issue? And we deal with that. The vaccination has been very important for us. We have been very fortunate to have, yes, there's strange voices saying strange things against vaccines, etc., fear, confusion. But on the whole, we've had a really good response to the offer of vaccines. Currently, we have vaccinated 84,000 persons with the first dose and 49,000 persons with the second dose. There is no difference currently in terms of how we treat business travelers versus tourists versus locals. The protocols are the same. There are mechanisms to consider special requests, individuals who are ill or need medical care, diplomats, etc. There are mechanisms for those things to be reviewed and assessed and provisions to be made. But the provisions are essentially the same for everyone in an effort to keep Barbados safe. So I'll actually stop there for now. Sorry, you're muted.
Okay. Note to self, unmute mic. Ms. Lisa Valmon, good morning to you. Thank you so much again for participating and of course being one of the panelists here this morning. You are Permanent Secretary in the Ministry of Tourism in Dominica. Public health measures, tell us a little bit about that. Has there been any pushback in terms of vaccinations? How has COVID impacted ecotourism in Dominica? What has been happening?
Good morning, everyone, to my fellow panelists, as well as all of the team from PAHO and from the other islands as well. Well, first of all, in terms of the impact of COVID-19 on the tourism sector, as you would all imagine, it was tremendous. Just looking at some figures, for example, about 770 of our workers had lost their jobs, and COVID-19 also forced the closure of about 57 properties. So when we looked at the initial set of protocols we had put in place, it mandated that we had to have 14 days of quarantine. We allowed persons, citizens and so on to quarantine at their homes, but that did not work in terms of monitoring. So we had to move to mandatory quarantine. And we realized from the tourism sector that our average stay of 7 days, if you already have 5 days of quarantine and then another 2 days to wait for tests, that would not work. And so we implemented what we call the Safe in Nature certification. Safe in Nature, which was a managed experience. And Safe in Nature is a certification that starts off at the airport. So everybody who is interacting with any of the tourists had to be Safe in Nature certified. Safe in Nature also allowed tourists to have what we call a managed experience. They can have that at property, or they could go on Safe in Nature certified tours, water-based and land-based activities, and they could enjoy that within a certain bubble. We had to, of course, put in place a monitoring team, the Safe in Nature COVID-19 monitoring team, which was made up of private sector as well as public sector. And we pulled on board our Dominica Hotel and Tourism Association, our Dominica Association of Industry and Commerce, persons from our Discover Dominica Authority, as well as, and critically, officers from Environmental Health Department. So we have that team that goes out really, and their responsibility is really to monitor the Safe in Nature certification program. Okay. Safe in Nature certification program. And that has been the real way in which tourism has been able to thrive within a COVID-19 era. We have some success stories that even when we do the testing, because we still require them to do their testing, a first test when they arrive and then a test on day 5. And even on those day 5 tests, when those do come up positive, we have only had about 13% coming up positive. But even when those come up positive, when the contact tracing is done, there has been no contacts coming out positive out of that. So we're seeing that even if we do have the positives, the Safe in Nature certification is working because it's not being spread in the communities and even amongst the hotel workers and the taxi drivers and the tour operators and so on. So we count that as our major success story as to how we have been able to really reopen, albeit limited, but still reopen within a COVID-19 pandemic. As I mentioned before, some of the ways in which that has been able to work is a monitoring group. We also have at all of the properties COVID-19 point persons. We have the Ministry of Health surveillance system. As some of the colleagues mentioned earlier, we have implemented a wristband system where persons receive their Safe in Nature wristband that gives the public the assurance that, you know, we are able to identify those persons. So anytime you see that person with a wristband that says Safe in Nature or mandatory quarantine, you know that person is not supposed to be there. And there's a hotline that persons can call directly to report on those incidents. As I mentioned, the hotline, in terms of persons going out, we also have the hotline via which they can make appointments for their testing to return to their home countries and so on. In terms of your question with regards to the difference between regular tourists and business tourists, we had put in place specific protocols for business tourists, business travelers, but that was all under the umbrella of Safe in Nature. So we had allowed them, for example, to have limited meetings within the Safe in Nature properties. Persons can come in, but that would have to be monitored in terms of social distancing, mask wearing, sanitization before and after, and so on. So there was a slight difference, and there was just a specific set of protocols put in place for the business travelers as part of Safe in Nature. In terms of the social components and social measures, we had regular public briefings. Every Thursday, for example, we would have public briefings on the measures in place, and we would have a lot of stakeholders come on stream and, you know, talk about their experiences, reinforcing the protocols and so on for the bus drivers, how they sanitize, ensuring that persons wear their masks and that sort of thing. So that was a major way in terms of getting buy-in and getting the confidence of our citizens as well, that we are able to reopen tourism within a pandemic, but health and safety remain our priorities. Of course, we had regulations in place in terms of curfew and quarantine and so on. And importantly, it was very important to have consultations with private sector, public sector, and all of our monitoring teams, as well as our technical committee, involves persons and representatives from the private sector. So we feel that we are all tackling this on the same page together, because at the beginning it was sort of a challenge in terms of the private sector and the public sector. So we said, let us have all of our groups with private sector representation, so we are able to implement that. So those are just some of the, just in a nutshell, some of the ways in which we are able to survive within the pandemic. With the vaccination coming on stream, we have introduced new protocols for vaccinated travelers, still requiring quarantine, but of a shorter period. And then, of course, introducing a special wristbands for vaccinated travelers. And they still have to quarantine, as I mentioned, as part of Safe in Nature, but it's just that it's a shorter period. And that has been embraced. A lot of the travelers have actually indicated that when they come in, they feel that vaccination is sort of a VIP treatment that they get, because, you know, when you pass through the airport, we have a special line for them, and, you know, they can go to their properties and just do 2 days, do their PCR test on day 2, get their results, and then they're free to free to roam, as we call it. So that has been, like I said, Safe in Nature has been the main way in which we have been able to really, and it has been working because even when we get the positives on the day 5, there's been no spread coming out of that.
Ms. Valmon, one quick question. You mentioned mandatory quarantine. What was the fallout like in terms of returning nationals? Was it a small percentage that made a mandatory quarantine necessary? I know in the beginning we would have had returning nationals in all of the countries. You would have been given the opportunity to quarantine at home, but of course there was a major fallout. What was that fallout like in Dominica?
It was, I mean, just first of all, persons were itching to come home because it was felt that where they were coming from was in a much more serious situation with regards to COVID, and Dominica was safe. So even when they came home, yes, they agreed to the 14 days of self-quarantine, but it didn't work. I mean, you would see persons at the bars, at the restaurants, doing shopping, doing transactions. And I mean, Dominica is so small, so when somebody has returned home and so on. So when we realized that more and more of those cases are being reported, that persons are supposed to be being quarantined and they are out in the public, we really had to take a hard and fast decision to really mandate quarantine at the government facility. At the beginning, even before Safe in Nature, you had to quarantine at the government quarantine facility. And it's really out of that now, then we segue into Safe in Nature. But we had to really make that decision early on, probably about 2 or 3 weeks into the implementation of those protocols, we had to make that decision to mandate quarantine.
Yeah, I'd just like to share, we had the reverse sort of direction in Anguilla. It's interesting to discuss, and it's the way things evolve, because in the beginning we had it government facilities, but at virtually no cost to the returning residents. So that worked well for a while. It's a controlled situation. We had 0 breaches, but of course, and everyone's holding their breath for the end of this pandemic. So after a couple months of that, well, I mean, the resources ran out and we had to transfer the cost, but not only that, persons were pushing to say, I'm coming home, I have my house, why can't I quarantine at home? So again, we capitulated. However, we also had to ramp up our efforts in terms of the monitoring and the surveillance. And we had the police constables come on board and they would go around with the health team to make sure that there were no breaches. Of course, there were many more than, we went from 0 to several breaches, going from that control situation to a less controlled situation, but that was understood. But there was a strong attempt by the government and the governor at least to support that, realizing that we were taking on more risk. So it's just interesting to see the reverse sort of direction with that and the considerations. Very interesting.
Interesting to know. As you mentioned, police, national security has been very critical in terms of all of our protocols really and truly, and ensuring that tourists as well as the citizens remain safe and everybody adheres to the protocol. So national security has been, again, one of our major partners in ensuring that works.
So I'm going to throw this question at you, Ms. Valmon. In terms of the so-called elite, we're not dealing with any conspiracy theories here whatsoever, but vaccination, tourism, and the global rollout of vaccines, of course, is a huge advancement towards reopening the economies all across the region. Now, as I said in the beginning, it is definitely a game changer as we move towards obliterating COVID-19 totally. What are your plans, your new travel vaccination protocols? What are you planning to implement? And how does that affect the average tourist who may not have been vaccinated, but is insistent that there is a so-called elite traveler, the person who has been vaccinated?
Okay, so the major difference in terms of vaccinated and non-vaccinated for us is the length of time of quarantine and the day on which you do your PCR follow-up test. So if you're vaccinated, and we've started implementation of the new protocols since May 18th, if you're vaccinated, you would still require all of the pre-travel requirements in terms of your health screening questionnaire, your negative PCR with swabs taken 72 hours and so on prior to arrival. And of course, when you submit all of that, you have to get a health approval to travel to Dominica. That is the only thing that will allow you to even board to come to Dominica. So that is being taken care of even before you arrive in Dominica. Once you arrive and you're vaccinated, you would have to go through sanitization, of course, and mask wearing, ensuring that you have your mask, temperature screening, and then you go to document validation. Document validation is taken care of by the Port Health facilities, and they ensure that all of your documentation is in place, your validation, your vaccination certificate is valid, and then you go on to Immigration and Customs, then you go to your safe in nature property. So you do the managed experience, as I said, for 2 days, and on day 2, you have to take your PCR test. One of the other benefits of being vaccinated is that your turnaround time for receiving your results is now 24 hours as opposed to 48 hours. So that's the main difference. If you're not vaccinated, you come in, like I said, the same way, but you have to do your quarantine for 5 days. You're tested PCR on day 5, and you can wait up to 48 hours in terms of your test results. So that's been the main difference in terms of vaccinated and non-vaccinated. And we have seen slight increase in numbers in tourists coming in from May 18th, and even more so, more vaccinated travelers coming in. On average per day, you can see up to 60–70% of the flights, of the persons on the flights coming in are vaccinated. So that has been a main game changer for us in Dominica, for the tourism, for the properties. Although they were clamoring for vaccination protocols and so on, now because the quarantine time has been reduced, you find that persons no longer have to stay up to 5 and 7 days at the property. They now only have to stay 3 days, and then they can move about to any property. Doesn't have to be certified. So that's been the main difference in terms of vaccinated and non-vaccinated. We are also looking at introducing new protocols for vaccinated persons coming in via yachts, because that is one of our major income earners in terms of the yachting sector. So we have, that is before cabinet in terms of those coming in via yachts.
Thank you, Ms. Valmon. Dr. Phillips, allow me to bring you back into the discussion. Tell me what factors are taken into consideration the protocols, vaccinations, tourism, the travelers?
That really gets to the heart of things. Thanks for the question. I think in short, what we've really sought to do is look at the evidence in terms of what are the risks, what are the benefits, including the health side of the house. And as importantly, we have today and in Barbados, we work closely with our tourism partners because the economy is very tourism driven, and therefore we have to include those considerations. So issues around what the risk of transmission, the benefits of adding an additional test, length of quarantine, all of these are things that we have looked at and that we continue to look at as we seek to balance those issues in terms of protection and economic benefit. The issue of vaccination, I think is very important, and we've been quite fortunate to have support from PAHO and from others through COVAX facility, etc., to be able to get vaccines on island. And that's also something that we've been looking at, sort of what's our level of vaccination, particularly among our most at-risk groups, and what is the evidence of effectiveness of the vaccine generally, and then also in relation to particular variants of concern. That's one of the things that we've recently been factoring in. It's in our current protocols, and certainly some of the considerations that we're making now in terms of possible changes have to do with that particular issue of variants of concern and what's the effectiveness of the vaccine that we're using locally against those variants. So in addition to the 5 days of quarantine for the unvaccinated traveler, and essentially test and move, as it were, test, get your result back within 24 hours and move. You can test on arrival or at your facility, the approved quarantine facility. We also have the consideration of, has this person been to a country of concern, a country where their variants of concern at a level that we think is significant or worrisome? And for those persons, we currently have a 7-day quarantine. We have a limited list of countries. We're looking at other countries, and we're looking at other measures, how we would take into account vaccination versus unvaccination in terms of, or unvaccinated versus in terms of persons coming from those countries of concern. So all of that is part of the process currently, and there's always this issue of what does the evidence say, and what would be beneficial economically if we could do it safely, and we try to get the two to meet, and I think fortunately, because we have a variety of mechanisms that facilitate the interactions. One of them I mentioned, we have a cabinet subcommittee on COVID, which includes health and tourism, but other ministers and other areas represented, which helps to pull those things together and to help the policymakers to make those difficult decisions.
Thank you very much, Dr. Phillips. In the interest of time, I know there's so many more questions that I can ask all three of you, but I do have a question for the panelists from Kevin Padmore before we wrap up this discussion and go into Dr. Roberta Andrighetti. The question is, given the low rate of uptake of the vaccine in Grenada, what additional initiatives are planned to increase this to achieve herd immunity? And I'm guessing Dr. Charles would be able to answer this one as well. Dr. Charles?
Yes. Well, all of the measures that we were using before to generate demand all continue. But in addition, the thought is to now offer more incentives for persons who are, so the discussion now is on allowing events that will, cater to persons who are vaccinated only, and basically to step up on the education campaign. And yeah, these are, these are our plans. We hope that with time and with information, we will reach more persons and convince them to get vaccinated. And it is a work in progress. It's a work in progress.
Thank you very much, Dr. Charles. So this brings us to the end of our panel discussion. I do want to say thank you to Dr. Andrewen, Dr. Phillips, and Ms. Lisa Valmon. Of course, they will be around. They're not going anywhere for any questions that you may have after the session. I would like to invite now Dr. Roberta Andrighetti, and she is a Regional Advisor, International Health Regulations, PAHO WHO. Dr. Andrighetti? Now, remember, we will take your questions after Dr. Andrighetti's presentation. So remember, you can send them into the chat as well.
Okay. Thank you. Good morning. And thank you for the invitation to this very interesting discussion. And first of all, I would like to ask if you can see my shared screen. Okay. Thank you. Then I'll try to elaborate on the considerations on vaccination and international travel in the context of the COVID-19 pandemic. First of all, we have to When we are talking about certificates, we are talking about an official document that states that the information on it is true. But before getting to documenting truthfully some kind of information or status, there is a long way. And this long way is underpinned by a number of considerations that we can generally categorize under 4 groups. Consideration of scientific nature, ethical nature, legal nature, and in terms of digital technology. Now, if you look at the scientific consideration that could lead to the use and requirements of a COVID-19 vaccination certificates, we have to start with the, we would have to start with the evaluation of the vaccines against COVID-19 in this case, in terms of quality and safety in particular. And this is done through the WHO emergency use listing procedure. And up until now, there are 8 COVID-19 vaccine products which are included in that list, which is public. Then once a vaccine is included in the EUL, in that list, then the Strategic Advisory Group of Experts of Immunization, the SAGE, is tasked with elaborating evidence-based recommendations. And there is an evidence framework that has been developed for COVID-19 vaccine, which focuses on efficacy, safety, and duration of protection conferred by the vaccine. And to date, the SAGE has issued six sets of interim recommendations for the use of those 8 EUL vaccine products. Another set of scientific consideration is related to the real world, because the EUL process and the SAGE, they look into efficacy, but in the real world, we have to look into effectiveness. And in this table is summarized what is the impact of the COVID vaccine, of the COVID-19 vaccine in terms of reduction of certain outcomes related to the infections. And we can see that for a very severe outcome, the reduction that is associated with the administration of the vaccine is very significant. Whereas when it comes to the impact of the vaccine, the effectiveness of the vaccine in reducing the onward transmission of the SARS-CoV-2 virus, there is more limited evidence, and the limited evidence which is available shows that the impact of the vaccine on onward transmission is less pronounced. And therefore, when we are talking about international traveling, if we would be interested in the reduction of the effectiveness in terms of reduction of severe outcomes to decrease the stress on the health services in the country at destination. And when it comes to international travel, usually from that perspective, we are always more concerned in looking at the effectiveness of the vaccine in reducing the chance of onward transmission. And in this case is limited. However, in relation to the COVID-19 vaccine, there are also a number of unanswered questions that have to be considered when it comes to the potential prospective use of a certificate. And these unanswered questions are related to the duration of the vaccine-induced immunity, to the effectiveness of the currently available vaccines on the virus variants, whether or not there would be a need and when of booster doses of the vaccine, how long the vaccine should be offered to a prospective travel, and other questions of this kind. However, hand in hand with the vaccine effectiveness, there is also what should be put into the equation is what is known in terms of duration of naturally induced immunity. Immunity induced by infections with the virus. And this is not completely understood. There is a recent publication by WHO regarding which summarizes the knowns and unknowns related to natural induced immunity. And what we know is that this type of immunity protects against reinfection for at least 6-8 months after the first previous infection. And it is under investigation what the evasion of the immune response by variant. What has also to be carefully considered, because testing of traveler is very popular, is that is not understood what is the correlation between serologic, the results of serologic assays detecting antibody and the protection against infection or reinfection. If we move to ethical considerations, the SAGE, while elaborating its evidence-based recommendation, takes into account a number of ethical principles. And these ethical principles are also captured and reflected in the interim position papers by WHO regarding the proof of vaccination of against COVID-19 in international travelers, and the ethical considerations which led to the current WHO position of not introduction of requirements of proof of vaccination as a condition for entering or exiting a country, are related to the limited availability, but more than that, limited access to COVID-19 vaccine worldwide, and also to the fact that the introduction of a proof of vaccination against COVID-19 could deepen the inequalities and also infringe the human right of freedom of movement. Now, then the SAGE in its different deliberations since January 2021, the SAGE is summarizing, I think, very well what the considerations are what are the considerations underpinning the current position of WHO in terms of science and ethical consideration. There is no sufficient evidence of an effect on transmission of the vaccine. Therefore, non-pharmaceutical measures, personal protection, physical distancing must continue to be followed, to be adhered to by both vaccinated and unvaccinated individuals. And due to the limited vaccine supply and very clear priority groups to be targeted by vaccination, international travelers cannot be regarded as a population for priority vaccinations just for being travelers, because it would counter the principle of equity. But nevertheless, together with ICAO, ILO, IMO, WHO has issued a statement calling for the prioritization of seafarers and air crew members in the context of maintaining essential traffic. Then the position of WHO resulting for scientific and ethical consideration is crystallized in the temporary recommendations issued by the Director General in the context of the public health emergency of international concern. And since January 15, the temporary recommendations call member states not to introduce requirements of proof of vaccination or immunity as a condition for entry, And then this temporary recommendation was softened a bit in the set that was issued on the 19th of April, where by the temporary recommendation is member states do not to require the proof of vaccination as a condition for entry stroke exit. Now, in the in its advice to the WHO Secretariat, the IHR Emergency Committee as for the WHO Secretariat to continue elaborating on the risk-based approach to the for resuming international travel in the context of this pandemic. And in that document that was first published on the 16th of December last year, the main concept is that international travelers should not be treated neither as COVID-19 cases nor as contact by default. And that guidance document presenting a risk-based approach is structured around 4 main headings: risk assessment, risk mitigation, and risk communication. However, recently, due to the rollout of the COVID-19 vaccines and also to the emergence of the SARS-CoV-2 variants of concern, the document has been updated and its publication is imminent. Where we still, as WHO, we are still not going into is resuming, and we are explicitly indicating that in the document, we are not embarking into any guidance regarding the resuming of cruise line traffic because of the complexity and the lack of full understanding of what has happened in terms of dynamic of transmission at the beginning of the pandemic, and also on occasions when there have been attempts to resume cruise ships traffic and didn't end up very well in terms of transmission. Then in the updated document, what has been added and reiterated is sort of captured in this slide. There is a sort of, in terms of risk assessment, there are no changes in terms of assessing the epidemiological and capacity situation, both at origin and at destination. And that document that is going to be published soon explicitly present a number of questions to inform the risk assessment, both for inbound travelers, but also for outbound travelers. And this is one of the main changes of the document, because there is this first recognition that limitation for outbound travelers are also need to be considered for implementation. And in terms of risk mitigation, the document is presents the two sets of measures. What we as WHO Secretariat we regard as basic risk mitigation measures that should be in place in any case and always, and supplementary risk mitigation measures that sort of attempt to mirror what is been done, adopted by national authorities through the pandemic. And in particular, we are these supplementary risk mitigation measures should be referred to the testing of international travelers, and that document stresses once again that testing would make sense upon or after arrival, if anything, and there is the currently available evidence presented and summarized in this document. Then once again, we have to stress, I know that I'm not very popular, but that pre-departure testing, unless is introduced as a deterrent, is not a mitigation measure that has a public health impact. And then among the supplementary risk mitigation measures, there is also the quarantine of international travelers, and there is evidence presented about the effectiveness of the quarantine approach, and for the first time border closures and travel bans are contemplated as a measures that came out of the closet eventually, because this is consistent with Article 18 of the IHR. And this new guidance document, most importantly for this meeting, also addresses the role of a proof of vaccination against COVID-19 in the context of international travel. And as always, the third set of guidance relates to risk communication, and it is unchanged with respect to the December version of the document. Now, regarding the proof of vaccination in the updated guidance document that is going to be published regarding the proof of vaccination as against COVID-19 as a requirement, as a condition for entering or exiting a country, we reiterate the current temporary recommendation that both national authorities and conveyance operators should not require the proof of vaccination as a condition. And also the document is going to present a number of considerations regarding the proof of vaccination, as well as the recovery status of travelers, to exempt these individuals from other measures such as testing or quarantine. Then this individualized approach to the application of public health measures would, for countries that would consider such exemption, should be sort of follow these two lines. For fully vaccinated individuals with EU-held vaccine, this exemption could be applied if the EU-held vaccines, the complete course of EU-held vaccine was applied at least 2 weeks prior to the traveling, or the exemption from other measures could be applied to individuals who can prove a previous SARS confirmed SARS-CoV-2 infections and have received and they are basically free of infection 2 weeks prior to departure, and this the disease, the infection was detected within the previous 3 months from departure. And once again, as the SAGE did, irrespective of the vaccination status, all incoming travelers must adhere to personal protective measure and physical distancing measure at destination, but also on conveyances. Now, what is the situation in the region of the Americas in terms of international travel related measures adopted in the context of the pandemic? I captured this measure as of on the 29th of May, like a week, 10 days ago. The first thing is that overall, throughout the pandemic, all the 35 PAHO member states have generally maintained essential international traffic, generally. But as we have heard from the previous speaker and from the panelists, there are all sorts of combinations and permutations of mitigation measures that have been adopted, applied, and these combinations and permutation of mitigation measures adopted are rapidly changing over time, and it's very complex to keep track of what is going on. But as of 10 days ago, there are 22 member states in the region of the Americas that have implemented either a selective based on the origin or a general entry ban for conveyances or individuals. There are 25 of the 35 member states that requires travelers to register online prior to departure. 24 member states require quarantine for incoming travelers based on the origin of the traveler or as a subsidiary measure depending on the application of other requirements, like if on the basis of the presence of a negative in the absence of testing, quarantine would be the alternative. There are 31 member states that require a proof of negative test result obtained prior to departure. And the proof of these negative test results is regulated in a very heterogeneous manner with wide variation of intervals prior to departure regarding the test being performed, and also great variations in terms of laboratory methods adopted. Then there are 19 member states that require incoming travelers in different, either because of the origin or because as an alternative to other measure or on a general basis to undergo testing upon or after arrival. And there are in up to 18 member states, travelers might be requested to present both negative test results obtained prior to departure and as well as testing upon or after arrival. And then we move to the situation of the immunological situation. 6 member states are waiving exempting travelers from other entry requirement based on the proof of previous SARS-CoV-2 infection, natural infection. 10 member states are waiving these exempting travelers from entry requirement based on the proof of vaccination against COVID-19. And there is one member state, which is a Caribbean member state, St. Kitts and Nevis, which is requiring the proof of vaccination against COVID-19 as a condition for entry, which technically is breaching IHR provision, including temporary recommendations. Now, in terms of digital considerations, which may underpin the use or requirements for a COVID-19 vaccination certificate, WHO has recently changed the scope of its work in this respect. And what the WHO is going to do to facilitate the electronic issuance of digital certificates will be limited to the issuance of guidance. And therefore, this guidance would not only set the specifications for electronically documenting the COVID-19 vaccination status, but also for the standards for capturing, documenting SARS-CoV-2 test results, as well as the recovery status for SARS from COVID-19. Now, then WHO will not have any role in facilitating the establishment of a global IT architecture for verifying and exchanging in this respect. In this area, in terms of architecture, digital architecture that are being set up, there is IATA, which has introduced the Travel Pass initiative and is targeting government, airlines, laboratories, and as well as travelers. And there is the EU digital COVID certificate, which has been, which is going to be launched at the beginning of July, I think, by the European Union. And what the European Union is doing is in compliance. In fact, the European Union, the states of the European Union are applying Article 44 and Article 57 of the IHR. And both IATA and the EU digital COVID certificates will allow the recording, the documentation, the electronic documentation of vaccination status, negative test result, and recovery from COVID-19. For the WHO to move, if the scientific and ethical conditions are met, for WHO to move forward with the potential prospective introduction of a COVID-19 vaccination certificate, WHO has to operate under the framework of the international health regulations. And as of today, the only health-related certificate document that state parties may require to an international traveler as a condition for entering or exiting is the proof of vaccination against yellow fever recorded in the International Certificate of Vaccination or Prophylaxis. And nevertheless, I have to be clear that there are no IHR provisions which are preventing countries to exempt incoming travelers from other requirements based on the proof of vaccination. And to allow state parties to introduce a proof of vaccination against COVID as a requirement, as a condition for exiting or entering, we would have to activate in a non-mutually exclusive and possibly sequential manner a number of IHR provisions, starting from the application of this IHR provision would have as ultimate goal to lead to the generation of an Annex 7 bis, which for COVID-19 we would mimic, would be the equivalent of the current Annex 7 for yellow fever. The activation of this provision should have as one of their goal the modification of Annex 6, the model certificate for the model international certificate of vaccination or prophylaxis, to allow capturing real information, documenting in a truthful way information related to the vaccination status about COVID, and possibly, as suggested by the IHR Review Committee on COVID-19, the activation of those provisions should lead to some fine-tuning to accommodate the use of digital technology while maintaining the paper flow of the use of paper certificate. I think that's all I wanted to share with you, and thank you for having been very long, but this is where what we are at for the time being. Over.
Thank you very much. Thank you very much, Dr. Roberta Andrighetti, for that very informative presentation. In terms of time, we're going to take a few questions. In fact, we have a few questions in the question and answer box. So I just want to run into it right now. I do know that we still have Dr. Darlene O'Meara Taylor. She's with us. She's a family and community health advisor. I understand Dr. Gibre is still here with us. And of course, we have the panelists. So let's dive right into the questions. Let me get here. Okay, Andre Holder, twofold question. He says, will the Caribbean region require vaccinated persons to produce vaccine passports upon entry? And would it become mandatory in the near future while traveling in and around the Caribbean? Of course, I know Dr. Andrea Gretti would have touched a little bit on that, but we're still going to answer Andre's question.
Okay, if it is for me, at this moment in time, the use of the documented proof of vaccination against COVID-19 cannot be introduced as a condition for entering or exiting because of the scientific unknown, and also not to deepen inequities, not to infringe the human right of freedom of movement. Then at this point in time, that using a vaccination, a proof of vaccination against COVID-19, the passport, as a sole condition would be infringing the current, the IHR provisions. We do not have any, the IHR doesn't have many teeth, then we cannot challenge more than publishing this information. That's all we can do, but this is the situation. Nothing prevents the Caribbean sub-region to adopt a sub-regional approach as the EU did, where yes, within the community, freedom of movement on the basis of that passport, but not as a sole condition for movement.
Thank you, Dr. Andreetti. Now, I do have another question. It comes from Randolph Cato. Dr. Phillips, I don't know if you want to take this one. It is noticeable, the question is, it is noticeable that in most jurisdictions, public information has focused on international or internal measures, and issues. Shouldn't there also be a concerted effort to share information on what has been happening elsewhere in the region, especially on the measures that have had to be introduced in severely impacted neighboring countries, for example, Trinidad and Tobago and Suriname, to help drive the urgency of the need for vaccinations and compliance with protocols within the country? Dr. Phillips?
Thanks so much. I would agree with the questioner that there is benefit in us sharing our experiences because we can learn from each other. There are things that Barbados is able to do because we have seen things either work or not work elsewhere, and I think that that's something that we certainly need to continue to do. Of course, individual countries would tend to share their information, or CARICOM may share, or CARFA or PAHO may share on behalf of the region. But Barbados, for example, would tend to share the experience in Barbados, as well as guidance from various reference agencies, including PAHO, and what the literature says on particular things. But I do understand the power of stories and of experience in moving people to understand things and to make decisions. And there is benefit in us speaking to things in those kinds of ways, in addition to the science-based, evidence-based sort of approach.
Dr. Phillips, I think I'm going to stick with you for a bit because I do have another question here from Barbados, which came via email. It's from Paolo Baldi. He's the honorary consul of Italy. And the question is, if the vaccine is old to be effective, I'm not sure if that's old, why are travelers, regardless if they are vaccinated or not, still required to test 72 hours before boarding a flight?
Right, so sure, thanks for the question. And I'm fortunate in this instance to be able to point back to Dr. Andrighetti's presentation, in which she spoke about the effectiveness of the vaccines to reduce symptoms, to reduce hospitalization, to reduce death, to reduce transmission. And none of those numbers was 100%. I believe it was 40 to 60% is the evidence that she quoted around what we currently know. And that may vary slightly depending on the particular vaccine and the particular setting in which it was used. So yes, we understand that vaccines are important and they have a powerful impact in terms of reducing the burden of disease and the risk of transmission. But because there can still be illness and people can still transmit, we cannot treat them as though they could not transmit. So we still need to take some precautions in terms of determining their status and managing that risk. Yeah.
Thank you again for your response, Dr. Phillips.
If I may, I'd also like to take the opportunity to echo the sentiments of Dr. Phillips. What we've tried to do in our exit strategy as we try to relax measures, really moving towards routine surveillance and approaches for this COVID-19, is to base the relaxation of measures on certain, mainly on the vaccination coverage assumptions. So we're trying to counter these unknowns, but also ensuring that at the very least, at the very minimum, before we make these bold steps, our vaccine coverage is at least 70% at a minimum. So for the same reasons, the same unknowns, even the so-called breakthrough infections, I will say that the evidence so far is quite encouraging. And as the data become more robust, I think countries like Anguilla will be prepared to make more bold steps. But for the same reasons, we still have those requirements as well. And any relaxation of those will be dependent on how this thing evolves, and mainly our vaccination coverage should take those kind of risks.
Thank you, Dr. Andrew. And on that note, let me ask you this. Will the CMOs, ministries of the various islands officially document their experiences during this pandemic for future reference? With respect to Anguilla and Grenada, what were the main differentials which allowed you to keep your residents/nationals so very safe?
We certainly would like to document, if we catch our breath with this response, as soon as we get a chance, and it's been evolving, and we've certainly made a commitment to document our response. I believe that we were able to let basic public health science prevail. We never lost sight of the test, isolate, contact, trace mantra, the concept of the epidemiological triad, where you have the host, the environment, the organism. You just don't let the organism take foothold. And I think sort of abridging that is the concept of the hierarchy of infection controls. The hard stuff really works. The elimination is at the top, PPEs is at the bottom, and we really kept that focus deliberately. Why I'm saying that, because there's pushback in terms of the quarantine and the testing and so on, and we just had to keep our eye on what really works in terms of all things are taken to get a comprehensive response, but not to lose sight of the role of each of our measures in terms of the hierarchy of infection controls, and to put our foot down, even when we were asked to waive on certain measures and to relax certain things, just to say, look, this is just good public health. We were allowed to do so. We had the right mix in terms of the political stability across two governments, changes of governors, and also the confidence of the public. Very important. So I said, besides that, we were also in an enabling environment with the right mix of entities and direction. And I think that's what really helped. But basic public health, I think we were allowed to practice basic public health here and keep our population safe.
Thank you so much. Another question, Shanley Store. Considering that persons with underlying conditions were more at risk, do you foresee this influencing your country's focus on preventative care, sponsoring more health-based programs, and a possible partnership with medical companies to give reduced rates to persons who get healthier through lifestyle changes? Dr. Omer Taylor, would you like to answer this one?
Hi, good morning, everyone. Nicola, do you want to rephrase that for me, please?
Okay, let me get right back to it for you. So Shanley Store says, considering that persons with underlying conditions were more at risk, do you foresee this influencing your country's focus on preventative care, that is sponsoring more health-based programs and a possible partnership with medical companies to give reduced rates to persons who get healthier through lifestyle changes?
Thanks. So I know many countries, and unfortunately I can't give a country perspective, but I know for sure PAHO has been working with the countries to actually scale up and to highlight the importance of the services needed to provide it to persons with underlying condition in the setting of the COVID-19 pandemic. Because as we all know, this is definitely the high risk groups. And we're seeing evidence of people now becoming more concerned in their preventing measures and keeping updated with their medications. And a lot of effort have been put into that in terms of communication, but we also have ongoing programs that have been now being rolled out in the countries to encourage this. Now, in terms of this being a partnership with the private sector, as you said, to provide reduced prices, I think this would be a country decision that they would need to analyze. I know for sure we always encourage partnership with the private sector and with all sectors. And I think that would be something very important to take into consideration in the response.
Thank you so much. I'm looking at our time factor. I would like to throw this one in. Tiffany Hoyt. It says, Dr. Andrighetti has stressed that proof of vaccination cannot be used as entry or exit requirement, which we understand based on IHR. However, a number of countries are structuring their quarantine requirements based on vaccination status for the purpose of quarantine protocols. Is there any database that countries can use to verify? Dr. Andrighetti?
Yeah. Okay, I would like to be clear on this. There is using the proof of vaccination as a condition, sole condition, or as condition requirements for exiting or entering is breaching the IHR. There is nothing in the IHR which is preventing countries to exempt from other measures on the basis of a proof of vaccination. Yes, the proof of vaccination should be used as an alternative, as a facilitated alternative with respect to other more stringent measures, quarantine, exempting from testing, and this kind of thing. And all these conversation, obviously, bearing in mind that we cannot go down to zero risk of exportation or importation. This is has to be clear. With respect to capturing the information, is extremely complex. There is no central database. There are a number of no-profit or industry or public health websites, which are or diplomatic website of certain countries which are trying to keep track of all these requirements. And for instance, for me to compile what I just presented in the slide, it took me an entire day because there is a need to double check the official governmental sources information, and not always is they're easily accessible, but congratulations especially to the Caribbean countries, because a major step forward in information sharing of entry requirement, as the requirement was made with respect to the pandemic. Now I know more or less where to go, and this was fantastic. I hope it goes on, but then everything has to be double checked. There is no repository.
Thank you for your response, Dr. Andrighetti. I think this will be our last question. The question comes from Dixon Narayan. It says, what if after receiving the first shot of the AstraZeneca vaccine, I tested positive for COVID? How long should I wait for the second shot? Secondly, what are the side effects of the AstraZeneca vaccine if I tested positive for COVID? I'm not sure who would like to take a turn at this one.
Hi, Nicole. I think I probably should take a turn at it. So yes, as Roberta clearly stated, we are guided by the advice from the strategic group, which are the group of experts on vaccines. And what they're saying is the person, if they took a first dose and they require a second dose, they should wait till they are fully recovered, which would be an information that the doctor that is attending you is going to say, well, I think you're fully recovered. So minimum, they're thinking approximately 14 days in between. So the person should definitely take the second dose, but of course, this has to rely on them if they're symptomatic or not symptomatic. If the doctor believes that you have no symptoms. So if there's asymptomatic, then you could wait approximately 14 days. Was there a second question follow up on that?
There actually was a second portion.
The symptom, the side effects.
The side effects.
So the general side effects are the ones related to fever, chills, body aches. Some people get nausea, vomiting, and it usually would sort out in 2 and 3 days. We've even had cases of what we comment in the office, somebody even had all these symptoms at the same time. So, you know, some people could really be, but it's a natural mechanism of the body while responding and developing antibodies. So this is naturally to be expected, and most vaccination sites are actually provided this information. Once you get the vaccine, they give you this general guidance of what symptoms to expect and what you should be taking.
Thank you so much. I believe this is where we have to wrap up. I know that we intended this to be a session that was just about an hour long, but too much information. And of course, we want to absorb all as we continue the fight against COVID-19. And as we all know, vaccines bring us closer. So we do have a lot of work to do. I'd like to say thank you to all our panelists. Thank you to the office, the PAHO office in Barbados and the Eastern Caribbean countries. Thank you so much for facilitating, and of course, all the participants. I hope that you are leaving with the necessary information to move forward as we focused on COVID-19, vaccination, and international travel, the role of the vaccination passport and immunity certificate to revive the tourism economy in the Eastern Caribbean, one step at a time. And I hope the information here was useful. Thank you so much, everyone.
Thank you very much, and all the best to everyone. Stay safe.